Open. Hello? Hello? Okay, cool. Okay, everybody. Hello. We're doing stuff a little bit differently today. Hopefully everything works on my end and on everybody else's end. I'm just gonna hope. But hello. If you've never seen me before, I am Spectral Anomaly. Second year med student. And what we'll be doing is talking and studying together. We're doing cardiomyopathy today. Well, rather, we're doing a lot of CVS pathology. We're going to do a lot of CVS pathology stuff today. Hopefully it works. I'm just going to pray that everything works on everybody's end. If it doesn't, just let me know in whatever chat there is. I will do my best to troubleshoot because, oh my lord. It took me a while to like get everything set up. I was like watching YouTube tutorials after class, after like studying today. And then more studying is gonna happen anyway, so like all I do is study. My whole life is studying. But yeah, so the schedule for today is gonna be just doing some amboss after yapping about cardiovascular, the CVS pathology. For the CVS patho part, we're gonna first go over like congenital cardiomyopathy, like congenital vascular anomalies. You know, pretty on brand considering I'm a spectral anomaly. You know how it is. You know how it be. We're learning today. As per usual. Yeah, I figured. But okay. I do hope everything's working. Legitimately. I really do. Because if it doesn't work, I don't know what to do. I'm gonna do my best. Regardless. But yeah. So my whole schedule is up on the thingy. Because tomorrow, well, actually no. We're gonna be doing like viruses for cardiovascular disease, but also pathology. There's a whole lot of things. But yeah. Okay, we are gonna start. I just realized I also have like the TikTok stuff on my end, so I have to like mess with this as well. But we're gonna go over we have congenital anomalies of like the vascular system on board first. So but yeah, so hopefully people understand what I'm talking about. Also, for some reason, to those that joined on TikTok, hello. I did not think this was going to be happening. Low-key. I was a little bit surprised. But welcome. If y'all are interested in hearing a medical student yap about everything in the gosh darn world, welcome. That's what we're going to be doing today. So, here we go. So, when I mean cardiovascular pathology, pathology is really just the study of like everything that's going fucking wrong in your body. Like, no, like obviously that's the simplest way to think about it. So let's go into like some possibilities here. So what was I saying here? I was already getting on a tangent. Sorry about that. But okay, so for pathology of the cardiovascular system, there's a lot of pathology stuff that I just kind of forgot, so we're gonna go through this together. Hi, Maddie. Hope you're doing well. Thank you for the lurk. But yeah, so we are gonna be doing it this way here. So I'm gonna first look at like some congenital stuff. So there are some congenital, like, so first you have to go over, like, what the hell are blood vessels? Like, I would think so, because, like, not everybody knows what the hell is going on. So, doing a little refresher is always a good idea. So, So for like blood vessel histology. Oh my god. There we go. Now it works. Beautiful. Love that. Okay. But so like the main way the main components of blood vessels are there are like technically 5 layers, but like 3 main layers with like 2 sandwiching layers in between those 3. But the main constituents of blood vessel wall is endothelium, smooth muscle, and connective tissue. So I'm gonna write that out right here. So just think of main constituents as main ingredients in our blood vessel sandwich. You know what, I'm gonna move us over to blood vessels. Like, we're just gonna go straight onto like blood vessels here. Like, I use Amboss for a lot of my like studying, but for if you can't understand if you cannot pay attention to what I'm saying, you can also just look at what's on here as well. But basically, but if I wanted to like read the summary out here for blood vessels are an integral component of the circulatory system. There are like 5 different types of blood vessels. So in order of like the type of circulation you got, so you got arteries, arterioles, capillaries, venules, and veins. Venules and veins, they're the ones that go way back up to the heart. Arteries, arterioles are going to be the ones that go away. Like the main thing that blood vessels do is they just carry blood, nutrients, and all that stuff away and to and from the heart, as like I would hope everybody knows. You know, I would hope so, but I mean, if you don't, that's okay. That's why we're here. And again, if y'all have any questions, just let me know. It's almost like I have an open forum for a damn reason. But okay, so endothelium, smooth muscle, and connective tissue. You already know this. These are the main ingredients. But all this, oh wait. Like, all of this stuff goes into, like, obviously, what the hell is in the blood vessels. Like, the layers of the blood vessels. So, if we look at the layers of the blood vessels, go to layers. So, this is going to be from inside out. So, 1. So, 1 minute. I'm gonna make this. This is gonna be 1. This is gonna be 2. And this outer layer is gonna be 3. So, for 1 is the intima. 2 is the media. 3 is the adventitia. Like, those are the layers. There are different kinds of, like, blood vessels, but, like, this is, like, just the main components. Like, that's how all this is. That's how all that works. So, arteries. Arteries, like, they're just, so if we look at, like, the large blood vessels, arteries are the ones that take everything away from the heart. Everything that goes away from the heart. So, they're like the large blood vessels that take away things from the heart and they bring it either to the rest. They put it into systemic circulation, or it can go into like pulmonary circulation. That's really how it is. That's really how it be. But okay. There's different kinds of like arteries, or different kinds of arteries, but like the main thing is that all arteries will take shit away from the heart. There's like the large ones, so the elastic ones. The elastic arteries are like the aorta and the major branches. Their main function is to like propulse blood, obviously. I'm gonna put up a table here, that way it's a little bit easier for everybody to see. So this is our little table. That way we can keep that up there. That's important to know, obviously. But yeah, so examples of large arteries are going to be your aorta and major branches. The medium are going to be the branches of the elastic arteries, so your coronary arteries or your renal vessels, and your small arteries and arterioles. These are the ones that regulate your systemic blood pressure, and these are the ones that do the flow limitation. The morphology of so morphology basically means like how these are like structured. Morpho means like shape, basically. So, morphology of the large vessels, as you can just see on the table, these are media-rich and elastic layers. They have poorly defined adventitia, but they have a vasa vasorum. Because these blood vessels, the large blood vessels are so large that they need their own blood supply. So, obviously, that's what the vasa vasorum do. That's how that makes sense. That's how that works. The morphology of the medium are going to be that they're media. So the media layer, the middle layer, layer 2, is going to be the one that's super rich, and it has more developed adventitia, which is the 2 and 3 are going to be more developed in your medium layers, while your small arteries have they're indistinct. They're indistinct compared to like the media. They're indistinct compared to the large and the medium, because obviously they're a lot smaller. But for the large vessels, the large vessels, the adventitia have vasa vasorum, which are the small blood vessels that supply the vascular wall. Vasa vasorum, VASA, vasa, like vessel, literally the vessel of the vessels. It's a little Latin lesson for you. Like here, large blood vessels. They contain arteries and veins which have 3 main microscopic wall layers. Here are the layers. Tunica intima, this is from the inside, the lumen, which has the hole, like the closest to the actual hollow part of the vessel, because everything's tubes. Sublayers got the endothelium, you have the subendothelium, and the internal elastic lamina. And these are the components, as you can see right here. That makes sense to you? I hope so. But okay, arteries. So arteries, their main function is going to be the transportation of arterial blood from the heart to the periphery, except for like the pulmonary artery, because that takes stuff from the heart to the lungs, because that has deoxygenated blood. Or if we look at the umbilical arteries of fetal circulation, that takes oxygenated blood away from the heart to the fetus, because that's how that works. Elastic artery, but yeah. Hopefully we're understanding things properly. Like, I'm just going over, like, the reason why I'm even going over this is so that when we actually get to the pathologies and stuff, so the pathogenesis of diseases of the blood vessels, we're not going to be, like, completely SOL. Because if we know the basics, then we can go further, obviously. Oh boy. Oh boy, did not mean to do that. Come on. Come on. Is it deleting it now? Yes, perfect. Cool. But yeah, so I just kind of yapped about like how blood vessels basically work, because if we don't know how blood vessels basically work, how are we going to know what's up when there's something wrong with them? Obviously, that's what we need to know. But okay, so I don't really know what else you guys really need to know, because like a lot of this stuff is pretty normal, but we can go further. So we already kind of know what veins are. Veins are thin-walled like vessels with like pretty small, pretty quote unquote scanty elastic tissue. They're not very compressed. They're just very smooth. And they have valves that prevent backflow of blood, because these are the ones that take the blood that's in the systemic system back to the heart. So I'm going to draw a person here. It's not going to be very good, because I don't really need it to be very good. This is not art class, even though I am using an art tablet. The main system, so like if we look at this, I'm going to use this to be our arteries. So, and then like this is going to be the heart. So heart's here. So let's say this is the right, so this is the left side. Heart is here. Arteries are going to take everything from here. So all this is going to go out. But obviously, our human body is kind of a closed system when it comes to this shit. So what's going to happen? How do we get that blood back? Well, you get that blood back through something cool called the veins. So, like for example, when you get to the capillaries, there's gonna be like a little meeting. They have a meet cute if you want to like really make it. If you want to be really quick and dirty with it, they have the arteries and the veins have like a little meet cute at the capillaries because that's like where the actual site of gas exchange, nutrient exchange, etc., etc. That's where all of that happens. So. And basically everything goes back. I hope we're understanding what I am doing. I didn't really want to use any other colors. I only got 3. That's all I want. And that's all you're getting. But yeah, so I already mentioned. So capillaries are the meet cute, basically, between the arteries and the veins. There are different types of capillaries. So capillaries. So you know what? I'm gonna make a different color here. I'm gonna use this color for capillaries. So I'm gonna put this color up here. This is gonna be for our capillaries. So sides. Meet cute. We're just gonna assume that there's a meet cute right here. So that goes back. Meet cute. Meet cute right there. Capillaries. Capillaries. But there are different kinds of capillaries. So these could be continuous. They can have like a continuous endothelial layer. So they're not going to have little holes. They're not going to have little cavities in there because the cavities, so they can be fenestrated, like have tiny openings or have really big openings. These are for like transportation of like the bigger shit. So like you have hormones, you have if you have like hormones, if you have like nutrients and stuff, that's where they can go in and that's where they can come out. So fenestrated, they have tiny openings or pores, they have literal perforations. Discontinuous means they can have like sinusoids. Sinusoids, they're even bigger holes. And those bigger holes allow for like whole formed things to come out. So like remember how everybody says that our blood vessel or our blood comes from our bone marrow? Yeah, exactly. That's where that comes from. Lymphatics, and we have like lymphatic vessels, we have lymphatic capillaries, and we have lymph nodes. I'm not going into lymph nodes that much at least. But so now we're gonna go into like the different kinds of congenital anomalies and the pathogenesis of the diseases of the blood vessels. So I'm gonna throw away this drawing really quick. Yeah, if any of you guys are enjoying this, please let me know. Being in the chat is fun, I believe. But okay, so for the type of vascular anomalies, we can have like really weird narrowing of the vessel lumina leading to ischemia. So we have like the provocation of like intravascular thrombosis. So like if you form a clot, in your blood vessel, obviously that's bad. I I don't know how else to say that. Obviously that's bad. I'm gonna move this onto that part in the blood vessel. So hopefully. Okay, so we're just gonna go on to specific things. I'm gonna write some stuff in here, and then we're gonna look that up on Amboss, and that's what we can use. Oh wait, let me see. One moment, y'all. Oh my god, I hope I passed my micropathology. Okay, I passed. Good enough. Okay. Oh my god, where's my drawing thingy? There it is. So, we have... We have provoking intravascular thrombosis. I'm just gonna label that as clot formation. Because what that happens, that will lead to vessel obstruction and embolism, and that leads to an infarct. You know, like your MIs, that's what that means. That's what I mean by that. And then weakening of the blood vessel wall, just like straight weakening of the tubing. Okay, so, you know, like an aneurysm. So basically what happens with like the formation of an aneurysm, it's like a weird ballooning in the wall of the blood vessel, and then like, what obviously when you have like a weird balloon happening, the material of the blood vessel gets thinner. Which means this area is a lot more fragile than like the rest of the blood vessel around it. And so, what can happen here is that this could rupture, and rupture is bad. I feel like I don't need to explain that. I feel like I don't need to explain it that hard or that much. But like we're gonna go on to congenital anomalies. I'm gonna open up. We're just gonna go on to like. We're just going to aneurysm first. Just aneurysm overview, basically. So, what an aneurysm is, I basically explained like the nitty gritty of it, but according to Amboss, an aneurysm is typically defined as vascular enlargements with a diameter that is greater than 1.5 times that of a normal artery. True aneurysms are arterial enlargements in which all three layers of the vessel wall are weakened and form part of the aneurysmal wall. False aneurysms are extra-arterial hematomas contained by the surrounding blood vessel or surrounding tissues and or the tunica adventitia that maintains persistent communication with the arterial lumen. We're going to explain what the fuck that means later. But arterial dissections are vascular enlargements caused by the separation of arterial wall layers as blood enters the intima. So, like, blood enters in between those layers. Hi, Hika! Hello! How are you doing? You catch me in a very blood vessel time right now. How are you doing, though? I hope you're having a good day. Oh god, you're at work. You're always at work. You're always at work. Well, I mean, you are a radiologist, so that makes sense. Also, I am so happy. I passed. I am one of like the small percentage that passed our pharma exam. I am very happy. Oh yeah, wait. Oh, so you're central. Okay, you're central time. For me, it's still like it's like only. Yeah, I'm like one of the pharma had like 38% passing. That was the passing rate. I'm a part of that 38%. I am very excited. Oh, EST. You think I remember EST? I don't remember the difference. I didn't realize that EST is like behind us now. Okay. Yeah, daylight savings time. I forgot. I always forget those things. But okay. I'm gonna keep yapping now, though. Also, Hika, random question for you. Um, what does a like a congenital, like a saccular aneurysm look like on like CT? If you find any pictures, or like if you see any cool pictures like at work and you're allowed to like show them, you should send me one so I can look at it, please. Because I actually don't. I can't. I know. I understand how it's supposed to look on like figures. I don't know. I can't tell on like other stuff. I can't tell. It's hard to see. But yeah. I'll look it up on Radiopedia, as per usual. But okay. So, we're gonna go into congenital anomalies. Oh god, I should probably like just erase it this way. There we go. Here we go. Okie dokie. Okay, cool. So, oh, thank you! Actually, wait. You can send it to me over Discord, actually. Because I cannot share that on... oh god, is my VTube studio, like, freezing? No, I'm gonna cry. How dare. Okay, good, it's working again. But yeah. But also, Hika, I figured out how to, like, get a Discord so that, like, everything works on there. So, yay! I have a Discord now. But okay, so, we have a berry aneurysm. Oh wait, oh my god. I'm surprised you aren't friends yet, actually. Thank you. Thanks! Oh wow, that's crazy looking. Okay, I see now. I'll post it up on stream in a second. But yeah, so congenital anomalies. I'm no longer gonna digress. Okay, so we got berry aneurysm. We have our AV fistula. Fibromuscular dysplasia. Or anomalous coronary artery origin. But okay, so hopefully everybody understands what I'm talking about here. I hope so, at least. But okay, so I'm going to talk about the first one, the berry aneurysm. These are the most common types of intracranial aneurysms, and these are the ones that will most commonly cause like the subarachnoid hemorrhage. Though they're sometimes referred to as congenital. These aneurysms are not present as birth, but they do develop over time because of an underlying defect in the media of the vessel wall that makes it susceptible to dilatation. So for intracranial arteries, the thickness of the cerebral arteries, they're thin, they do not have an external elastic lamina, and they have few elastic fibers, and they're very thin, and they have less perivascular support because you have a whole lot of stuff going on It's a brain. Obviously. Obviously, there's a whole lot of shit going on in your brain. Oh, wait. Also, Hika, you just have to. Oh, right. Just do exclamation DC and it'll get you the link. Joanna. Yep. There you go. You got the link to the Discord. Welcome. But okay. So, for extracranial arteries, they have a really thick. The entirety of the thickness of the entire wall is going to be super thick compared to intracranial arteries. They have an internal. They have the external elastic lamina. They have elastic fibers. They have an adventitia, like an actual thick adventitia, and they have more perivascular support because it's surrounded by tissue instead of just cerebrospinal fluid. With the pathogenesis, the patho. Oh my god. The pathogenesis of an aneurysm. Oh god, I can't say that like that. So basically, about 90% of saccular aneurysms are found near major arterial branch points in the anterior circulation of the circle of Willis. But like multiple aneurysms exist in like 20 to 30% of cases based on like a series of autopsies. But like the reason why these like aneurysms even develop. So first one is going to be hemodynamic stress. Then there's going to be the hemodynamic stress causes excessive wear and tear breakdown of the internal elastic lamina because like in cerebral arteries there are not many anyway. What? Oh, that's okay. But yes, welcome to the bottom. Welcome to the bottom of an energy drink can. That's the brand. That's the brand being exhausted and unhinged every day, forever. But okay, so the hemodynamic stress causes excessive wear and tear and breakdown of the internal elastic lamina because there's not really much to like even have in the intracranial arteries. So if you break down what you got, you're gonna lose it all. Which then leads to accelerated degenerative changes in the vessel wall, which then leads to the development of the aneurysm. Aneurysms most commonly arise at the ACA, which is the anterior communicating artery. Well, dude, I drank like 2 Alani's today, and I still had a headache. And I also couldn't even. Today was rough. But I drank water today, though. That's the problem. I drank water and I drank my Alani. So, like, I had a lot of water. I even had, like, fiber today. Because, like, I also drank my, Oh! Alani is the only energy drink I can find here where I am. Alani is basically just, like, less fun Celsius. They taste about the same. Honestly. They taste about the same. Though I will always prefer Celsius over Alani. Celsius just hits different, as you know. You know they do. I prefer Celsius. Though my favorite kind of energy drink is gonna be the Celsius Live Fit because it's not as carbonated, which means I can chug it faster. So, one moment. We're gonna go back to what I was talking about here. So, we're gonna draw out the circle of Willis. Oh god, I really hope I can draw this out from memory. I really hope I got this right. I hope I got this right? Oh no. OBS, you better not. Okay, thank god. I just hope my stuff doesn't freak out too badly. But okay, so we got the anterior cerebral artery. I think I drew this right, like right here. A, A, C, E, A. We have this one, which is the ACO, anterior communicating artery. We have the middle artery. We have the anterior carotid right here. So IC. We have the PCA, which is the posterior cerebral right here. PCE. I'm gonna make this. This is a very bad drawing, but it's good enough for what I need. For what I need here. This is gonna be the PCO. One moment. So PCO, and this is gonna be the basilar artery. Basilar artery down here. And when I mean that aneurysms most commonly arise at the anterior communicating artery, where it connects with the anterior cerebral artery, so so we're gonna have a lot of our aneurysms, like 40% of them, happening like right there. 40%. Here, between the posterior communicating into the middle, this is gonna be like 20%. This is gonna be over here is gonna be 4%. Oh my god. There we go. 4%. These are percentages of where we're gonna most likely have an aneurysm. I hope I got that right. Hika, you're keeping me honest here. I think I got that right? Right? Did I do it right? I'm like doing this mostly off of memory. Because like if I don't remember this, if I don't at least remember this much, then that means I'm cooked. So I really hope I got this right. Right? Oh, let's go. I did. Okay. Yay! Hey, look, at least I got the anatomy right. If a radiologist tells me that I got the anatomy right, then that means I'm on the right track. I'm so happy. This is an achievement for me. The person that is terrible at anatomy is now told that I got the anatomy right. I am so happy, legitimately. Yay! Look. If I got it right somehow, then I got it right. That's Pog. That's Pog for me. But okay. Although aneurysms more frequently occur at like the anterior communicating, like where I drew it up there with the 40%, the risk of rupture is greater in the PCA. I don't know why though. Oh wait, this probably is why. I wonder if we can find out. Wait, why is that the case actually? But okay, so arterial dissections by location. Mass effects, let's see what that means here. So the, oh, signs and symptoms caused by compression and or displacement. Okay, that's what they mean by mass effect, I see. But okay, so we're just gonna have this picture up here while I keep talking. Basically, so what was I doing? Right, so okay, what was I saying actually? Alright, so although aneurysms more frequently occur at the anterior circulating arteries, the risk of rupture is greater in aneurysm in the posterior circulation involving the retrobasilar, the posterior cerebral arterial system, or posterior communicating arteries. The occurrence in children indicates like the role of intrinsic factors, because this usually happens like because of like wear and tear and like further factors going on later on in life. That's from what I literally just said earlier. Genetic disorders involving defective connective tissue and blood vessel development are often associated with aneurysm formation. So Marfan syndrome, Ehlers-Danlos syndrome, Oster-Weber-Rendu. There's like, is there like Klippel something 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 something? Oh my god, I'm like drawing a blank on the last one because I know it's Marfan's and Ehlers-Danlos. Those are the two I know off the top of my head. That's the ones I know I got right. I hope so. I hope I got it right. I hope. I'm just gonna pray. Who knows? But okay. But so that's for the development of the aneurysm itself. But like for risks of rupture, for the risk factors for rupturing that aneurysm, the biggest one is gonna be smoking. Second biggest is gonna be like high blood pressure. Third risk factor is going to be like the size of the aneurysm itself. Diameters that are less than or equal to like 5 millimeters or less. So diameters of like 5 millimeters or less have a 2% risk of rupture, but those that are greater than 10 millimeters have like a roughly 50% risk of bleeding. So the bigger like, you know, when they say the bigger they are, the harder they fall, the bigger the aneurysm is, the easier they'll burst. That's what I mean. And for growth, so there's like growth, site, family history, and like intracranial pressure. So for the growth, most intracranial aneurysms develop over like a short period of hours, days, or weeks, attaining a size allowed by the like elasticity limits of the aneurysm wall. And at that point, the aneurysm will either rupture or undergo stabilization and hardening, but the likelihood of rupture decreases unless the size of the aneurysm is fairly large at the time of initial stabilization. The site, I already kind of mentioned it. Look at the picture here. Yay! I'm so glad I got those two right. Look, if the radiologist is telling me that I'm not wrong, then then that means I'm doing well. That means I'm not completely cooked from my exams. Also, I found out that tomorrow, the quote-unquote, so where we are in my school, we have these things called the comprehensive exam. We have to take our first one after M2, and then we have our second one after M4, like after internship. So it's like I'm already studying for step 1. What's another exam to add on to it, right? What's another exam? What's another exam that I have to study for days and weeks on end? It's almost like I've been studying for, it's not as if I've been studying for the MCAT or anything. Or not the MCAT, it's not like it's not like I've been studying for the USMLE Step 1 or anything. But they gave us practice exams, and I'm thinking of taking it on stream tomorrow, and then like maybe going through my thought process while I do those questions, and then auditing like if I get them right or wrong. I think that would be interesting. I don't know. I think it would be fun. I think it would be a fun stream. But back to what I was saying about like the risk factors. So we talked about this site. Look at the picture. Posterior circulation aneurysms have the highest rates of rupture. Don't ask me why. I don't know. I feel like that's going to be a radiology or like a neuro question. So Hika, can you explain? Do you know why? Medicine is a cram fest. Yes. That's we're in this field together. I want to get into it. Wait, I just realized I had slow mode on the entire time. Did I have slow mode off? It's off. Weird. But yeah, no, medicine is just like this. Damn, you don't know? Okay. Do you know, like, a brain radiologist? Can you ask for me? Is that okay? Do you know any brain radiologists that you can ask? Because I do want to, like, maybe get the answer to my question, because I am curious. But, like, for family history, familial aneurysms tend to rupture at a smaller size and at a younger age. But acute increases in intracranial pressure in like a third of cases. That can be due to straining or to something else I cannot say on stream. But the morphology of berry aneurysm. So when I mean berry aneurysm, I'm going to draw like a literal thing of berries because because I don't. That's just how I'm gonna have to like visualize it. That's just how it works. So here we go. They have a bright red and shiny surface. So I'm gonna pull up the color red and a thin translucent wall. So thin or absent tunica media. Fragmented internal elastic membrane. They have a hyalinized intima. So let's say that this is right here. Oh, wait, you're in a chat full of them? Yay! Can you ask that for me? I hope you get a good answer, and I hope my quest my I hope I know the answer soon. I am very excited. But okay, so like that's what they look like. They have a thin or absent tunica media. They have fragmented internal elastic membrane. They have hyalinized intima. And they have very thin adventitia. And the ruptures usually occur at the apex of the sac. So, like, actually, the way that I drew that shiny red ball, that shiny red berry, is probably where it's gonna happen. So the apex is gonna be like here. So that the rupturing is most likely gonna happen like right around here. Rupture right there. But okay, so now we're gonna go on to arteriovenous fistula, AV fistula. I'm just gonna say AV fistula. I'm not saying that whole word out loud. You cannot make me, unless like. The only way that I will say these words is if I am literally paid to. I am not paid to say those words yet. I am still a med student. Unless... But yeah. Yes. Why are the posterior ones... Why are the posterior aneurysms most likely to rupture? But yeah, I would really appreciate the answer to that question. But in AV fistula, we're gonna move on. That's an abnormal connection between the arteries and veins that bypass the capillaries. So like how I mentioned earlier, how the capillaries are basically the meet cute between the arteries and veins. If they don't want to do the meet cute, sometimes an AV fistula can form. The connection may consist of the blood vessel, a vascular channel formed by like a canalization of the thrombus, or an arterial or an aneurysmal sac. What? You found a paper? Oh my god! Thank you. You should send it. Okay, wait. So AV fistula. Okay, this is just how I'm gonna say it. AV fistulas bypass the capillary meet cute. Yay! Oh my god! Thank you for the paper. I am so excited to read this later. But okay, so the connection can consist of the blood vessel, blood vessel, vasc channel, through embolus or aneurysmal sac. Oh, I mean, I also can open it. I'm also on uni internet. Thankfully, I get access to it because of med school. I have the whole article now. I am so excited to read this later. Thank you so much. I did not get paywall, thankfully. Yeah! I appreciate it. But okay, so the pathogenesis of an AV fistula. This can arise due to from or be caused by a developmental defect, a rupture of an arterial aneurysm into an adjacent vein, a penetrating injury, inflammatory necrosis of adjacent veins, or like they can be surgically created, like for patients with on hemodialysis. Which is, by the way, where is Rico when I need him? But yeah, okay, we're gonna continue now. So, the clinical significance of an AV fistula, the increased flow, so basically, overall, the TLDRs, there can be increased load to the heart, which leads to high output cardiac failure. There can be arterialization of the veins, so there can be vessel abnormalities in the veins that can make them be like an that can make them like be like an artery, not like they put blood back to, not like they put blood away from the heart, but like that they look like arteries. I will look for a picture on here. So AV fistula, there we go. So we're gonna go into like these a little bit deeper after I continue talking about this, but like, so arterialization of the veins is already there. Now there's gonna be a palpable thrill. The blood flow into venous circulation can cause turbulence, which is responsible for the thrill that you can feel. Like when you feel it, it's like there's a little hum. I don't really know how to explain it, but I think like feeling a weird vibration or like a hum makes sense, right? It was like I felt it. I don't know how to explain it. So I'm just using what they say in the book, which is like you can feel a palpable thrill. Hopefully that makes sense to y'all. Well, I mean, it makes sense to Hika, because obviously, but like other people too. Okay. There's distal ischemia. Since much of the blood goes into like less resistant venous circulation, there is decreased distal arterial pressure, and this can cause arterial steal syndrome, where the distal extremity will receive lesser arterial blood, giving rise to like ischemic symptoms. So you can have like coolness, pallor, mild paresthesia, and pain. There can also be varicosities, so increase in the peripheral venous resistance. When there's increase in the peripheral venous pressures, this can lead to swelling, visible veins, so like varicose veins, and ulcerations in the limb. What was I saying now? I kind of forgot. Oh, and heart failure. That's another thing that can happen. Sometimes the heart responds to the decreased peripheral resistance by increasing stroke volume and cardiac output, which will lead to tachycardia. Eventually, that'll lead to left ventricular dilatation and then heart failure. So bad. It's all bad. Except like for the case where surgically placed for dialysis. Now we're going to go into like the different kinds of AV fistulas. So we have the carotid cavernous fistula, as we see on here. This is a so the carotid artery and the cavernous sinus. So this is what I mean. So this red thing here is the internal carotid artery. But then we have the cavernous sinus. This is the whole sinus is in here. So an abnormal communication between the carotid artery and the cavernous sinus. Basically, there is direct and indirect. The direct are going to be literal abnormal communications, and these are going to be considered the high flow carotid cavernous fistula. These are the most common type. And this is secondary. This is like due to head trauma. It can also be spontaneous, or it could be iatrogenic. Iatrogenic means like it's because of a surgical procedure. And the onset of symptoms for the direct cavernous for the direct CC fistula is going to be typically rapid. While for indirect carotid cavernous fistula, it's going to be less common, low flow, and it's gradual. Still spontaneous, but it's secondary to like cavernous carotid aneurysm rupture or cavernous sinus thrombosis, or due to like, this is rare, but this could be due to like Ehlers-Danlos or fibromuscular dysplasia. Where is my table here? I'm gonna look for like a really good figure of this. That way, like we can see it better. So, give me a hot second, y'all. Carotid cavernous sinus fistula, carotid cavernous CC fistula, basically. So. Why can't I find a good picture of this that's like simple? Oh, okay. This might be good enough. But like a lot of the symptoms you're going to be seeing with a CC fistula will be like headache, orbital pain, diplopia, blurred vision, pulsatile tinnitus, but the pathophysiology for this is like the main pathophysiology for it is going to be congenital malformation or trauma, which leads to AV fistula formation, which leads to arterial blood flow into the venous system, leads to venous compression or venous congestion, which leads to compression of the cavernous sinus structures. So like the cranial nerves that are in there, so like 3, 4, 6, 1, and 2. Hi, Mocha. I'm suffering. Save me. I have been studying so much. Save me. I'm trying to look for a picture. That way I can put it on the screen. But I can't find a good one. Actually, I think this one is good. Hi, I poop a lot. How you doing, buddy? You could never do this? You're in a higher gear than me! What do you mean? You're in a higher gear than me! Here. The fistula. Right here. Buddy, you used to be a dentist! I know you're the procrastinating queen, but like, my god! No, Mocha, you're the med student. I poop a lot 20 is used to be the dentist. No. Yo, you did this though! You did this! But okay. But like for the signs of congestion, you're gonna get like unilateral or bilateral pulsatile exophthalmos, so like your eyes gonna pop out. Okay, you know what? Fair. I also can't remember what I learned in M1. That's why I'm gonna be screwed. So as a dentist, what do I need to learn? Break teeth? Done? Wait, I do that all the time on accident. Like, oh my god. One time, oh my god, dentist time. One time, like, I was eating popcorn, and then I found out, oh, One time I was eating popcorn and I accidentally chipped my tooth. It was okay after. Less teeth equals easier fixing. I I don't think I believe you. I don't think that's real. I don't think you're right. I don't believe you. I don't really believe you, but I'll allow it. I will allow it this time. Remove all teeth, just get But I like teeth. I like my teeth. I like having teeth. One more tooth and nothing else, so you need to fix it. Okay, wait. Okay, wait. You might eat. I think you cooked with that. Wait, no. Oh no. Oh, so Hika, I think I'm right here. So like, the diagnostics for an AV fistula will be like a CT, MRI with or without angiography, right? And then you embolize it with like a coil, I think. Right? Am I right? Would you do an ultrasound, actually? Would you do an ultrasound with this? Like like a transcranial ultrasound? Actually, Mocha and Hika could help me. Oh my god, why? What have I... But yeah, okay. So like, I know the treatment. It's like just refer to neurosurgery. I just want to send this over to neurosurgery. That way they can deal with it, and I don't have to. That's the real answer. That's the real answer. Oh, oh, not sure about intervention, but you can't transcranial ultrasound in an adult. Bones with the oh, okay, yeah. Just TLDR, refer to neuro, because I don't want to deal with this. All I know is that they can cause hemorrhage or infarction, intracranial hypertension, vision loss, or death. So it's all bad. TLDR, it's all bad. Oh my god, wait. Do I have like an assignment? Okay. Oh. Ooh. Oh my god. Y'all, I'm so excited. We have a case. Oh, you diagnosed with a CT and MRA these days. You can ultrasound an AV fistula, though I see that for mostly dialysis AV fistula to assess patency. Oh, okay. Cool. Cool. Thank you. But oh my god, guys, I'm like really excited. I have a case to work on soon. I'm so excited. I'm gonna like screen share the case because ADHD moment. I don't want to talk about AV fistulas. They suck. They like high key suck. I don't want to deal with them. But yeah, no, we're gonna look at the case because I'm really excited. I just realized actually, like, there we go, there we go. I'm gonna put myself to the side. But okay, so we have a 33-year-old woman consulting at the ED due to abdominal pain with epigastric pain after heavy fatty meals. So she experienced epigastric pain with bloatedness and vomiting. She self-meded with antacids without relief. There was radiation of pain to the RUQ associated with fever and one episode of bilious vomiting. Oh, ooh. Okay, I'm gonna read this more fully. She self-medicated with mefenamic acid, 500 milligrams every 8 hours, and paracetamol every 6 without relief. Jesus Christ, that's a lot. That's a lot of meds. Huh. Crazy. Okay, she's non-hypertensive, recently diagnosed to have DM, maintained on metformin, BID, known allergies to cephalosporin and penicillin. Okay, her family history is unremarkable. She's a known smoker, approximately 5-pack years, and she's a regular alcohol drinker, like two beer bottles 3 to 4 times a week. Okay, okay, she likes to party. Got it, got it. She's 150 cm and 70 kilograms. I'll get the BMI on that really quick. Let's see what her BMI is. It's like what? Weight over height squared, right? 150 cm. 70. 31.1. Yep, I was right. Okay, so she's not tacky. Oh wait, no, she's not hypertensive. I mean, she's tacky, and she's tachypnic. Tacky in all the wrong ways. Her temperature is 38.2, so it's a little. She's feverish a little. Palpable conjunctiva, no jaundice, no icterus, and dry oral mucosa. Chest findings are normal. Abdomen was flabby, no surgical scars. Hypoactive bowel sounds. Abdomen was soft with localized RUQ gardening with direct and rebound tenderness on the RUQ. She is colic. She has acute cholecystitis. Okay. What clinical spectrum of infections and is SIRS and SRS is the patient presenting with at the ED? What are your bases? Okay. Ooh. Ooh. Interesting. Okay. So, yeah, she is CKK. I'm watching on large. There's a stone. There's a stone. Which clinical spectrum of infection? So, like, would we be concerned? So, like, with CKK. Sir. So, wait, why would you give us cephalosporin? This is a bad idea. I mean, I think this would this be considered a near miss? Hmm. Oh no, this would be a. I mean, this would be a near miss. Ooh. Clinical spectrum of infection. So, like, for post-op care, like, what could be the complications you can get? I mean, you can get, like, infection from maybe. I actually don't know. Hmm. Okay, what am I doing here? Clinical spectrum of infections and SIRS is patient presenting with at the ER. Right, you guarding. Oh god, I do not want to do all this math. I'm not looking at this. I am not looking at this. I just saw, oh, let's do a lot of calculations. No, I would rather not. No, thank you. No, thank you. I'm going to go back to CC fistulas now. Fuck this. Okay, okay, continuing. So, what was I saying? For CC fistula. And now we're going to go, okay, I talked about CC fistula. We're going to go on to the PAVF, which is pulmonary arteriovenous fistula. Okay. Arteriovenous fistula. Wait, where's my... Delete that. Then I'm going to delete, like... I'm going to delete that. Hopefully it's working. Cool, 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 cool. Amazing. Love that. So, PAVF. What the hell is that? So, a pulmonary, or, yeah, pulmonary arteriovenous fistula. Those are going to be the Basically, between the pulmonary arteries and the veins, this can be acquired, but can also be associated with like hereditary hemorrhagic telangiectasia, right? Still the same pathophysiology as fistula formation, flow of arterial blood in the venous system, venous congestion, so pulmonary symptoms instead of like the other one. What am I saying now? So pulmonary artery and veins. It's less common though. But clinical features are going to be dyspnea, hemoptysis, if like there's PAVF rupture. There's going to be chest pain, cough, cyanosis, clubbing, and also maybe murmurs and bruit. And they're going to be loudest during inspiration. Management, not all of them require it, but in symptomatic ones, you're going to be doing an embolotherapy. Complications are going to be stroke, brain abscess, hemothorax, polycythemia or anemia, or pulmonary hypertension. But yeah, that was pretty quick compared to like the other shit. But also, Mocha, you are gonna be concerned about my schedule for next week. But what I'm gonna be doing for those is gonna be shorter sessions, so like 2 hours instead of like 3 to 4. So hopefully it's not gonna be too bad. But okay, so now we're gonna go on to fibromuscular dysplasia. Fibromuscular dysplasia. So, these are non-atherosclerotic, non-inflammatory disease of the blood vessel that will cause abnormal growth within the wall of an artery. And it usually affects the medium to large vessel arteries. It's idiopathic. We don't know. It's unknown etiology. The sites of involvement are going to be mainly the renal. Oh god, I should delete this. Deleting that? Okay. Fibromuscular dysplasia affects young and middle-aged women, characterized by the proliferation of connective tissue and muscle fibers on the AV walls. And then there's stenosis that leads to impaired perfusion of the affected organ, causing ischemia. Okay. These symptoms of fibromuscular dysplasia vary depending on the site and the degree. The renal, internal carotid, and vertebral arteries are predominantly involved. So that is, oh wait, I was already gonna say that. Wait. Okay. Like renal artery, it's most frequently involved and occurs in like 60% of cases. This is gonna result in hypertension. Carotid artery, it's gonna be in like 20 to 30% of cases, and that's where you're gonna get like lightheadedness. That's where you're gonna get like lightheadedness, vertigo, tinnitus, headache, visual issues, and stroke. And the visceral limbs are like 9%, and then limb vessel is gonna be like 5%. The pathological classifications of this, so there's intimal fibrodysplasia, there's medial fibrodysplasia, and then there's adventitial fibrodysplasia. For medial, this is the most common, and it accounts for like 80% of renal and carotid cases. Intimal and adventitial are not as common, I think. Actually, wait, that's a Hika question. Hey Hika. Hey Hika. How often do you usually see that? Can you see that, like, on imaging? A fibromuscular dysplasia? How often do you see, like, different kinds of fibromuscular dysplasia? Like, how often do you see, like, the visceral and the limb vessels compared to, like, or not that one. How often do you see like medial fibrodysplasia versus intimal and adventitial? Can you see that? Oh, so you see the sequelae. Okay, got it. And this is why I'm very happy that I have other that I don't understand how legitimately I am glad you are here. I'm just high key surprised that like other doctors even sometimes watch my channel. I am very happy, but like I am also kind of scared like why I am perceived. Will I get a letter of recommendation after this? I'm joking. I'm joking. I don't need that yet. I am joking. I promise you. Okay, so you're not usually gonna see the specific wall changes, but you'll see the sequelae. Got it. But okay, now we're gonna go on. So the morphology of medial fibromuscular dysplasia, this is gonna have like regions of thick fibrodysplastic collagenous tunica media with regions of thin media, and it's gonna have the string of beads appearance. Because like there's thin, then there's thick, then there's thin, then there's thick. So that's what that's gonna look like. Cool. And but yeah, so that's the morphology of that. There's more on Amboss, and I can read that out because like okay, so the histopathology, the most encountered histology is medial fibrodysplasia. The pathophysiology, I already said it. It's gonna result in ischemia and stenosis, formation of saccular aneurysms. There's gonna be aortic dissection and arterial occlusion. There's gonna be formation of intravascular thrombi and embolization. There's also, for renal arteries specifically, there's going to be renal artery stenosis, which means less renal perfusion, which means increased compensatory activation of the RAS system, and then secondary hypertension, where secondary hypertension, that's the one that comes from, like, not, it's not primary hypertension. So if you fix the cause of the secondary hypertension, you fix the hypertension, basically. Clinical features for renal FMD is going to be like secondary hypertension, as I said, abdominal bruit, symptoms of CKD, and flank or abdominal pain. For cerebrovascular FMD, headache, neck pain, tinnitus, transient ischemic attack, stroke, Horner syndrome, and cervical bruit. Okie dokie. Now we're going to go on to the next one. What was I saying? Next one is anomalous coronary artery origin. I'm gonna go to my thingy and delete this. Okay. But now, next thingy. What was I saying? I kind of forgot. AL kappa. Oh, okay. Okay, so this is all they say about it. Basically, a rare congenital cardiac anomaly in which the left coronary artery arises from the pulmonary artery. And infants with this condition develop pallor, irritability, and diaphoresis after feeding, and this can progress to congestive heart failure. And now I'm going to continue yapping about it more. So the coronary arteries usually arise from the aortic sinuses, and the initial position of the aortic root, which houses the leaflets of the aortic valve, is occupied by the aortic sinuses, which is called the sinuses of Valsalva. Normally, the coronary arteries do not pass between the aorta and the pulmonary artery. But in coronary arteries with anomalous origins, both coronaries arise from one single sinus, where at least one of the coronaries will have to pass between the aorta and the pulmonary artery, or it can also follow an intramural path, which is it's where the first part of the artery is within the aortic wall, which then increase the risk for decreased blood flow to the heart, causing ischemia. So this is the normal atomic heart. I can draw it out right quick because obviously it's not supposed to look like that. Okay, so I hope I didn't draw this like too deformed. Low-key. I do not want it to be. Really? It is? Here's the thing. I only know about this so that I can study it for my exams because I want to pass and then like fully absorb the information. I'm like I don't really like how everything is so rushed, but I'm existing. But okay, back to the So this is our aorta. I'm gonna draw the aorta in purple and like have it be behind here. And then here's where like the stuff comes off of. This is a very bad drawing. Don't question it. Don't don't judge it. Don't judge it. This is a very bad drawing. I can do better. I can do better later. I'm not doing all the effort right now. No. That you're not making me. If you want me to, there's a way to. I'm not doing it. But okay, so basically that the normal I'm just gonna pull up a picture. I'm not drawing this. Here. Oh god. This is how it's supposed to look normally. But if it's not normal, they can either go intramural or intra-arterial, where the first part of the artery is within the aortic wall, that's intramural, but intra-arterial is where it is passing through and compressed between the aorta and the pulmonary artery. The TLDR for all of this, of what I've been saying, is that like clinical disease and blood vessel disorders arise because of narrowing of the blood vessel intima, thrombus formation, and weakening of the vessel wall. Aneurysms and AV fistulas can be congenital or acquired. Fibromuscular dysplasia often involve the renal arteries manifesting as hypertension, secondary hypertension specifically, and MI or infarction is a sequela of a anomalous coronary artery origin. Cool. Oh, cool. Look, here's the thing. The reason why I even do this is because like if I'm not gonna remember everything unless I yap about it because I can't. Passive reading just makes me fall asleep. That is how I fall asleep in lecture. Passive just listening, no like ability to just discuss. No, I will die. I cannot do it. I cannot do it that way. That is not how it works for me. That is not how my brain works. I could never. I could never. This is more fun. I have to make it fun for me so that it actually stays. That's like the main thing. If it's not fun for me, I'm not doing it. And this is fun for me, hence why I'm doing it. Hika. Yeah. What? Wait! What do you mean ones that you're hosting? You're standing up there! Huh? What do you mean? What do you... Oh! Okay, look, I thought you were like... Look, there were times, like... There were times in, like, actual cadaver lab lecture where I would fall asleep standing up. So maybe it wouldn't help. I would fall asleep standing up. I have done that before. It's not the first time. I am a perpetually EP person. Yeah, same. Uh-huh. You fall asleep standing up when you're, like, in a very nice, cozy, cold room. If you do that, you're not the only one that does that. I do that too. I also do that. That's the funny part. That's the funny part, you guys. I will sleep in any place. I don't care. It will happen. But okay, so we got through that part. Now we're gonna go on to... Oh god, I don't want to do vascular tides. But I'll do it. Because I don't understand them. What? You hate cold? Crazy. I could never. I love the cold. 5C is my comfort temperature. 5C is my comfort temperature. I cannot do anything in temperature that isn't, like, that cold. Yes, same. Same. No, I do that too. I either fall asleep at, like, very, very low temperatures or, like, very high temperatures. Like, there were times where, like, here, it's like 84 or 90 degrees Fahrenheit, right? I open the windows. I can't do anything. I cannot move. It's too hot to function. So I just fall asleep. That's so helpful, right? That's, like, super helpful. Yeah, no, legit. I will fall asleep in the summer. I will fall asleep in the winter. I love being cold. But also, if I'm too cold, then I get sleepy. It's a catch-22 for me. What am I supposed to do? But yeah. Vascular tides. Ugh. Okay. These are vascular inflammation injury, often occurring with necrosis. So... Okay, so the pathogenic mechanism. So, like, Although infectious organisms are more often cause direct vascular injury, they can affect blood vessels by eliciting an immune response. That immune response, that's the vascular type bullshit. Legit. Yes, I'll sleep. I just sleep. I love sleeping. It is a problem. Even if I sleep like a good amount. Like today, I slept like 7 hours. And then I was still sleepy. I am always sleepy all the gosh darn time. I am always sleepy. It's a problem, legitimately. But okay, so they're a heterogeneous group of rare immune diseases. These are vasculitis. So heterogeneous group of rare immune diseases characterized by blood vessel inflammation, vasculitis. Inflammation can lead to ischemia, necrosis, and or hemorrhage, with subsequent and organ damage. These are either primary or secondary due to an underlying disease, so like EBV, cancer, SLE, or drug use. Wait, what? Really? I'll just get a sleep study eventually, I guess. I don't know anymore. Maybe. Oh god, I do not want to talk. Oh, you know what? I'm just gonna yap. I'm just gonna yap, no writing. But okay, vasculitides. They often occur with necrosis. There's direct injury by infectious organisms. So for direct injury by infectious organisms, these are products of bacteria. These products of bacteria attract and activate inflammatory cells, which activate leukocytes and also humoral inflammatory mediator systems. And it reaches the blood vessel by direct extension, septic embolization, hematogenous spread and dissemination. There's also immune-mediated inflammation. This is due to the localization of immune complexes in the vessel wall, causing activation of both cellular and immune response systems. Activation of neutrophils and monocytes result in the release of lytic enzymes and toxic oxygen metabolites that cause injury to the cell wall. Basically, the TLDR of all this is everything's going to injure the cell wall. Oh. But, like, you know what? I should get checked. But, like, I don't... Here's the thing, though. I have recorded myself when I slept before. I don't have the typical breathing pattern. I'm just sleepy. I mean, also, even if I sleep, like, I don't know. I don't think it's sleep apnea, but I'm just gonna hope not. Because if it were, that's just a pain in the ass to deal with, Loki. I don't want to have to deal with any of that. I don't want to deal with any of that. That sounds like a pain. No, thank you. Oh, you don't either. Okay. It might be something I need to consider then. Wait. Oh. That's weird. That's concerning. That's concerning. Oh my lordy Lou. That is definitely a concerning thing to think about. I did not realize it could be like that, like that. I thought you had to have the comorbidities with the typical patterns. Fair. Fair. Thank you. But yeah, that's definitely something for me to think about then. But examples of diseases of vasculitides involving immune complex deposition. Already talked about it. Uh, Drug use or drug hypersensitivity, systemic immunologic diseases like SLE, vasculitis due to infections. ANCA, or anti-neutrophil cytoplasmic antibodies. These are circulating autoantibodies directed against the constituents of neutrophil primary granules, monocyte lysozymes, and endothelial cells. So I'll write ANCA on here. ANCA. ANCA. Okay. They can directly activate neutrophils and thereby stimulate them to release reactive oxygen species and proteolytic enzymes. And within the vasculature, this leads to endothelial cell neutrophil interactions and subsequent endothelial damage. I'm going to put a little table up here. It's going to be pretty simple. Okay. Mechanism of ANCA vasculitis. So, drugs or cross-reactive microbial agents induce ANCA, and then the subsequent inflammation or subsequent infection, endotoxin exposure, other inflammatory stimuli elicit cytokines that cause surface expression of proteinase 3 and MPO on neutrophils and other cell types. The ANCA will react with these cytokine-activated cells and cause injury and/or further activation. ANCA-activated neutrophils degranulate and also cause injury by releasing granule contents and reactive oxygen species. Direct antibody attack on though there are direct antibody attacks on antigens in the vessel wall, so anti-endothelial antibodies and anti-basement membrane antibodies. These antigens may be constitutive components of the vessel wall, though, such as endothelial cells and basement membrane, and this can predispose you to certain vasculitides like Kawasaki disease. Manifestations of vasculitis will depend on the organs involved, and so there's luminal occlusion. Luminal occlusion will decrease blood supply. Destruction of the blood vessels, though, can cause hemorrhage. Systemic manifestations are going to be like fever, myalgia, general weakness, loss of appetite, and weight loss. And now we're going to go under the Chapel Hill consensus criteria. Ugh. So, the Chapel Hill consensus criteria. This is going to be large vessel vasculitis. This is going to affect large vessels more often than other vasculitides. So there's going to be Takayasu arteritis and giant cell arteritis. Medium vessel vasculitis is going to be, as I said, predominantly affecting the medium arteries, is defined as the main visceral arteries and their branches, and the onset of inflammation is more acute and necrotizing than in LVV. So Takayasu, not Takayasu. Oh my god, what was I saying? I was going to say polyarteritis nodosa and Kawasaki disease. Those were the two I was talking about. And then small vessel, it's going to be ANCA-associated vasculitis, immune complex, and then immune complex small vessel vasculitis. Main things to consider are the fact that vasculitis may be caused by direct injury, often by infectious organism or immune mechanism that can involve immune complex deposition, ANCA, or antibodies directed against specific vascular wall elements. Despite the current nomenclature that divides vasculitides into those that affect large, small, and medium vessels, there are some degree of overlap as to the size of vessels involved. So yeah, that's an important thing to think about. So, and here's the picture. And this is the picture that I mean, the Chapel Hill criteria. Okay. And yeah. I do not want to go into all these vessel vasculitides. I just want to go into venous diseases and hypertensive vascular disease. So I'm going to go into those too, and then maybe play a video game. I think that'd be fun. I think it would be fun to finally play a video game. Maybe. Oh my lord. I'm just so tired. I want to play video games at some point in my life. But okay. So, we're going to start off with varicose veins. So we're gonna go into venous disease. I'm skipping the rest of the vascular types because there's like 4 lecture series in that, and I'm like, I'm not doing it. No, you're not making me. I already read all that yesterday. No, I refuse. So, honestly, wait a second. You know what I'm gonna do? I'm gonna edit my canvas. Oh no, I can't. Okay, that's fine. But okay, so for venous diseases, okay, wait a second, y'all. Okay, I'm back. Okay, so venous diseases. We got varicose veins on board, and there are like different kinds of venous diseases. So, but like, firstly, varicose veins, etiology. Let's go yap about that really quick. We're doing case. Okay, I'll read the case today, I guess. But okay, venous diseases, varicose veins. These are going to be dilated or tortuous veins of the lower extremities. Dilation of the veins is due to increased luminal pressure and loss of vessel support. Varicose veins and venous thrombosis account for like 90% of clinical venous diseases. One-way valves in the superficial and deep veins help blood flow back to the heart and lungs. The deep venous structures handle the vast majority of the venous system volume and is the high-pressure system of the venous circulation in the legs. The remaining blood vessel volume is handled by the superficial system. When the calf muscles relax, the valves close to prevent blood from flowing backwards into the lower part of the vein. That's kind of important. That's like kind of the main thing. But like, that's normal. But in competent valves, blood under the force of gravity will distend the section of the vein, causing the valves to like just get lower and looser, and then the blood it'll just kind of go down. So basically, let's say, wait, let me make this there. So like normally, this is our vein. There's gonna be blood in there, and it's just gonna be stuck there, and it's gonna be fine. Varicose vein. This is normal. Wait. Oh my god. Varicose veins. But these are normal. But in varicose veins, it's gonna be like this. The blood vessel is gonna expand out because, like, force of gravity, basically. It's because of the force of gravity that this stuff will just keep dragging it down. And that's how that works. And so, the etiology of varicose veins. There is going to be weakness of the venous valves and the walls. The veins have like the greatest tendency to dilate when the walls are weak or when the muscles or soft tissue around it is weak. Causes genetic because of the defective development of the walls, or aging, atrophy of perivenous soft tissues. The increased intraluminal venous pressure can be due to posture. Most important influence: when legs are dependent for long periods of time, prolonged standing contributes to the pooling of blood in the lower extremities, or pregnancy. Pregnancy because of the compression of the iliac veins by the enlarging uterus, which then increases blood volume. For the morphology of varicose veins, they have variable wall thicknesses, but they also have the tendency to form intraluminal thromboses, and there's going to be valvular deformities. The histology of the varicose veins, though, so there's going to be degradation of the medial elastic fibers with spotty calcification. So there's going to be phlebosclerosis, and this can be seen with special stains. Don't ask me what the stains are. I don't remember. Don't. I don't remember stains. The only stain I remember right now is the Guillaume stain for all of the ticks. Guillaume stain is for ticks, right? Like Ixodes tick, the other one. like oh my god, what's it called? Or like babesiosis, that's another one. But okay, for the clinical features of varicose veins, I'm going to go back to what I was talking about. Sorry, ADHD moment. There's also going to be thrombosis. Now to the clinical features of varicose veins. There's going to be venous stasis and venous insufficiency, characterized by congestion and edema, and impairment of tissue nutrition, and thrombosis. Thromboembolism is more common in the deeper veins, and contraction of the surrounding muscles will so like it pumps the contents of the veins from their attachment to the venous walls. There's also stasis dermatitis and ulceration. So this is like thin, shiny, bluish brown or irregularly pigmented skin. Varicose ulcers. This is going to be due to impaired circulation leading to ulceration and poor wound healing. There's also variations of varicose veins. So like portal hypertension is an increase in the blood pressure within the portal venous system. There is portal hypertension when the blood flowing through the portal venous system is blocked or meets resistance, as in cirrhosis, portal vein thrombosis, or hepatic thrombosis. And there is increased blood flow through the venous system in the case of AV fistulas, hypersplenism, or splenomegaly. Also, oh my god, I just realized I did not shout any of you guys out. Well, I mean, there's only you guys in chat, so you already know each other, but still. Next time. This results in opening of portosystemic shunts, which is, what was I talking about? Oh, I already talked about the hepatosplenomegaly, the hypersplenism, and splenomegaly. This results in the opening of portosystemic shunts, one of which is the esophageal plexus. And in the esophageal plexus, the veins here dilate and become prominent, opening the portosystemic collaterals or the shunts and causing varices to form in the rectal or the umbilical area. Now we're going to go on to esophageal varices. These are different kinds, so I'm on the subtypes now of varicose veins. Oh, chronic venous disease. Here's an article. Venous insufficiency, chronic venous disorder, CVD. But okay, so there are variants of varicose veins. I already talked about those, but we're going to go on to esophageal varices. So in esophageal varices, these are going to be dilated submucosal distal esophageal veins connecting the portal and systemic circulation. And the rupture of dilated mucosal esophageal veins during forceful vomiting are often lethal. Hemorrhage, another one. Hemorrhage can be caused by portal hypertension or obstruction to venous return by increased intra-abdominal pressure. For portal hypertension, veins in the esophageal plexus and the hypertensive portal venous system will dilate and become prominent. This will open other portosystemic collaterals or shunts as well, causing varices to form in the rectal or umbilical area. Once again, you know, hemorrhoids are just varicose veins, just in that area instead. Obstructions to venous return by increased intra-abdominal pressure. Hemorrhoids can also result from primary varicose dilatation of the venous plexus at the anorectal junction. This can occur through prolonged pelvic saccular congestion due to pregnancy or straining to defecate. This can be external, so in the inferior hemorrhoidal plexus, internal from the submucosal internal hemorrhoidal plexus, or mixed, both plexi. External hemorrhoids, these are going to be like below the dentate line, and they're going to have okay, so external hemorrhoids. These are inferior hemorrhoidal plexi. They're covered by squamous epithelium. They occur in areas that are invaded by cutaneous nerves that supply the perianal area. In acute thrombosis, there is going to be pain due to the distension of the skin around the vessels with clot or thrombus, and with resolution of the thrombus, the stretched skin persists as skin tags. The stretched skin persists as skin tags. That was a lot of words. Oh my lord. Internal hemorrhoids. So, for internal hemorrhoids, there's going to be submucosal internal hemorrhoidal plexi, and this drains to the portal venous system as well. Or this drains to the portal venous system. This is covered by transitional and columnar epithelium, and there are no somatic sensory nerves, so these are not painful. External hemorrhoids will be painful. These are not going to be painful, but the externals are. Pain may occur though if the internal hemorrhoids prolapse, causing spasm of sphincter, or when the hemorrhoids become incarcerated or strangulated. Perianal itching and irritation occur because of the exposure of the skin to mucus. And both external and internal hemorrhoids, being superficial, can cause bleeding. There's also mixed hemorrhoids, which is like literally just a mix of the two. Okay. Low-key, honestly, I think I want to take a break. And by that, I mean I'm gonna sleep more. And then we're gonna do more of this tomorrow. Because that is when I have access to the practice quizzes for the our version of step 1. Since I'm already studying for step 1 anyways, we are gonna go and do that. So yeah, I think it is time for me to maybe sleep because oh my god, I am tired again. But yeah. Hope everybody has a good day, etc., etc. I am Spectral Anomaly on all platforms. In various spellings. Bye.